you guys have all done my lecture for me, talking about variations and stuff like that, so I'm probably going to keep this quite short. Someone will ask me to do some variations around about some trauma, infection, orthognathic and pathology. Well, I think we've just heard that over the last half hour or so, basically. So it's going to be a bit repetitive, so apologies for that, but repetition is good about this. Hopefully it will sink in as well. So what about mid-face approaches? Well, I had a wee look at the literature and I come up with this. There's a multitude of variations that how you can get into the mid-face. Obviously we've heard the archetypal one is the one that was described originally by Weber, but actually Ferguson published about the same time, really, 1845, 1846, hence it's called the Weber-Ferguson. It's two different individuals. And then you've got the Diefenbach modification, and then you've got various other techniques which I'm not convinced about really. Anything going over the nose I'm not convinced about, to be quite honest with you, and my rhinoplasty surgeons would hopefully agree with me. As I say, there are various other ones. There's the transcolumellar, there's a gull wing approach, and then you've got the lateral rhinotomy, which was described, and then modification of that as well. So there is multiple ways to get into the extraoral aspect. What about intraoral variations? Again, I had a wee browse through the literature and I came up with these four. We've heard about the Caldwell look, two ENT surgeons, George Caldwell and Henry Paul Luke. The first D-glove incision was 1906, believe it or not, and that's the sort of traditional D-glove incision that we talk about. Deepesh talked about having this extended gull wing excision, and you can see there in B. Converse described another one, and this was one to put bone grafts high up into the maxilla, and then Walker talked about a low antral approach for orbital floor fractures. So these are sort of ones, and then the sort of full D-glove incisions really are the ones there, A, B and C. The original one was Cosson and Converse, hockey sticking it, not going far back as the 6. Kim modification was slightly shorter and slightly higher. And then you've got the Keen variation, the vestibular Keen vision there. So what about trauma? Again, we've talked about it. What are you going to use for that? Well, we know fine what we're going to use for that. Intraoral, we're going to use a Keen incision. We've talked about that. You stick an elevator in it, it comes out. How about mid-face fractures? Deepesh has eloquently shown a beautiful video on how you get access into the mid-face degloving. Absolutely right. Key to this is subperiosteal dissection. Don't violate the periosteum in any dissection in the head and neck region. As soon as you violate the periosteum, that's when your swelling starts, that's when the edema starts and stuff like that. So if it's a subperiosteal dissection, keep it subperiosteal. Don't violate it, because you will find you'll get a lot of edema in any part of the head and neck region, not just intraoral. Again, you all know, again, as I say, Deepesh talked about the dissection technique and how you do that. Careful dissection. Again, I do something very similar to Deepesh when I'm doing that. I angle my Colorado needle, so I create a good cuff of muscle for attaching my sutures at the end of it, basically. And it allows you access right up to the infraorbital nerve, as you can see there, for placement of your hardware. This was Walter's approach. So why did he do this? Well, he done this so he can get into the orbital floor for endoscopic view. I've done 2 endoscopically assisted orbital fractures in my career. I will never do another one, so there you go, there's my experience at 2. My ENT colleague, he wanted to do it, so I let him do it, and he said, oh, that was good, let's do it again. So I let him do it the second time, the third time, with 3 strikes and you were out, so I said, no thank you. Orthognathic, I'm telling your granny how to suck eggs here, aren't we? Yeah, you can move the maxilla in a whole load of places at the floor 1 level. It gives you allowed to do a traditional osteotomy line, but it'll also, as well, if you're doing a high-level osteotomy. You can extend the variation over the cartilaginous area there if you want access to the nasal radix. Quadrilangular incision, that's called a Kufter. Again, you can get access to that through the modified, slight modification of it there, and that's for a hypoplastic flat face maxilla where you've got this scleral show. Little points in closure, you all know about a VY closure basically. Which is good. Also as well, you can either do a running suture or it's entirely up yourself. The good thing as well, get good muscle approxication. As Deepesh said, dynamic muscle activity takes a long time to come when you're doing orthognathic surgery, so you've got to take that into account. And tell the patients that facial expression and that will be a little bit reduced. But good approximation of the muscular and the ligamentous system will help prevent that. Sin stitching, yeah, we all know about that. Why do we do it? Yeah, you don't want nasal flare. There are multiple variations of the ALA-based stitch. We can be here and we can have a conference on ALA-based stitching if you wanted, but I'm not even going to go there. We've all got our own individuals away. Please don't stand up and tell me how to do an ALA-based stitch. You do your own, I do my own. It's exactly the same result. Please, fine, we're not going to discuss that. Deepesh, here's your favourite topic. Minimally invasive orthodontic surgery. Yeah, I can see a rationale behind it, but to me, I don't understand it. Why you would want to do that. They only place 2 plates in the maxilla when they're doing this, so they can get back to the back, but their pterygomaxillary destruction, as Deepesh talked about, was some horrendous twist turn technique with an osteotome or something, and it's Alex Ferguson, who was a Scottish manager, and when the game was going into the extra time, you know, and it was coming up to extra time, and they always score in extra time, Alex Ferguson called that his squeaky bum time, yeah? So he had his squeaky bum time then. Squeaky bum is when I seen them doing that with the elevator, so no. Yeah, I can see it, but you know, you're only going to extend it a little bit, and if you don't violate the periosteum, as I said, you should be okay. Am I going to try it? I don't know. Just for interest, they done it for the mandible as well, so, and they showed some nice results, and they done it for the chin as well, so again, not convinced. This was called a telescopic genioplasty. I don't know how that differed from another genioplasty, it was just smaller, I think. Infection, yep, we all know that maxillary infections, they usually come, and they're restricted. We heard about the spaces, so the canine space is a common one. Being a member as well, you can get converted a CST, cavernous sinus thrombosis, by the connection of the ophthalmic vein, etc., etc. Your incision is going to be a vestibular incision. It's going to be dependent on, obviously, where your swelling are. What other spaces have we got in the mid-face? Well, you can get infections heading and tracking back the way. This is jungle territory back there, as I call it, the infratemporal fossa. Then you've got highways to go all over the place, basically. And you can see there the potential spread about that. You can see it going into this, up to the skull base, basically, danger area. How do you get into it? 2 approaches, really. You can do a step superficial temporal, or you can go intraorally, basically. Caldwell Loop, yeah, you all know about it. What do we use it for? Well, we all use it for doing things and taking things out that shouldn't be in the antrum, i.e. when we get into difficulty and stick a root in the antrum. This is one that one of my trainees decided it'd be a good idea to start the palatal root of an upper 6 into the antrum, so we fished it out. And again, you can use it for biopsies as well if you wanted to. It's a very nice incision just to do a little biopsy of it as well, and curettage there. I'm not an onco-surgeon anymore, I've given that up, but yeah, lots of ways you can get into it. I'm not going to talk about all the different maxillectomies and stuff like that. You've heard as well about maxillectomies, this is a Browning-Shaw classification again, we're not going to talk about it. 2 ways to get in, you can either do intraoral, you can do extraoral, or you can do both. Plan your surgery. We've all heard that common thing, plan, 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 so you know in advance what you're going to do, basically, and don't try and change your plan halfway through on the table thinking this is not working. If you've planned out properly, you've looked at your scans, you should know which approach you're going to do. This one's pretty straightforward. Mucoepidermoid carcinoma, it was an intraoral approach. We've got fantastic results, be able to put in a free flap as well. Extraoral combination approach, again, using a combination of the WF with an extension and an intraoral extension as well, and that way you get fantastic exposure. Again, if it's an oncological resection, you've got to remember as well, you want a margin. Where is your margin going to be? Periosteum, mucosa, and then God forbid it goes into the infratemporal fossa and you're chasing tumour up to the skull base. Not good. So just finishing off with a couple of ones. There he goes, subtotal maxillectomy. Again, you get great access right up. The orbit was spared in this one as well. Reasonable scar, and as I say again, you get fantastic access there. You can see there a tumour removal, and then a free flap, DCIA free flap in with a fantastic scar as well at the end of it there. So just think about, you know, what your pathology is it benign, malignant, what your trauma is, Also as well, if your orthognathic procedure, what kind of procedure are you going to do? Plan properly, think about your incisions, think about the variations you're going to do. Yeah, things do change on the table somehow, but if you've done proper planning, you should know what incision you're going to use to get through to the end result. Thanks very much. Thank you.